Hello, I want to thank the organizers for inviting me to talk about our work on focused ultrasound and immunotherapy. I'm Kathy Ferrara from Stanford University. Now, the areas of work within our laboratory include the use of agonists and activatable chemotherapy delivery in combination with ablation. Our overall goal is to develop translational and personalized strategies combining ablation with drugs or immunotherapy. And I wanted to note that there are about 469 current or soon to be recruiting trials combining different immunotherapy agonists and other treatments. And therefore, there really is a big space in which to think about how best to accomplish these goals. Now, our laboratory uses MR focused ablation in our preclinical studies. We've been using the IGT system, and we typically shoot for a temperature of about 65 degrees centigrade. We apply that temperature within a small region of interest that's typically a circle. So about a 2 millimeter circle in a 5 millimeter tumor is used to guide the increase in temperature. We've been using these strategies in the treatment of breast and pancreatic cancer. Our greatest translational goal is the work in pancreatic cancer. Now, pancreatic cancer is particularly a goal because it affects tens of thousands of people each year. The survival rate of 10% is relatively low and quite low, and there is a need for improved treatments. Now, our preclinical work with the IGT system in both breast and pancreatic tumors has demonstrated the opportunity to partially ablate the tumor and to observe various changes. For example, we would typically intentionally leave a boundary of viable tumor, as you see in the upper left histology. We would frequently see a small island of apparently viable tumor, but truly heat-fixed tumor in the center. That's actually in the little region with the red box at the top. So we would typically see right in the center of the ablated region some heat-fixed tissue. At the boundary of the tumor, we would typically observe enhanced vasculature and some extravasated red blood cells, as well as some immune infiltrate. And we can observe in the lower right the dilated vasculature and, again, some extravasation of red cells in those regions. Now, our laboratory has developed methods over the years to radiolabel anything from small molecules to peptides and dendrimers to micelles and liposomes. And in particular, in recent times, we've been radiolabeling adeno-associated viruses for gene therapy. The goal of PET imaging of these therapies, including gene therapy, is that we've attached a radioisotope to the construct of interest. That isotope is scattering positrons, which eventually hit an electron, and there's an annihilation event, giving off 511 keV photons in two directions that are almost perfectly orthogonal to one another. The reason for doing this is that we can achieve picomolar to femtomolar sensitivity and track the pharmacokinetics of therapeutics in the whole body. We can track many kinds of constructs without changing their properties. Now, we find in our strategies we've published in the past that ablation can enhance therapeutic accumulation. For example, in this study by Andrew Wong, we demonstrated that the ablated tumor shown with the blue arrows on the right would have an enhanced accumulation up to about 25% injected dose per cubic centimeter in the ablated tumor. And that's greater than the contralateral tumor or greater than that observed in the no ultrasound control. And again, here we're tracking liposomes in this particular case. The maximum tumor accumulation can reach about 40% injected dose per cubic centimeter when we're looking at a circle ablation, and that's greater than we achieved with a grid or with a single point ablation, and greater than observed accumulation than observed in the contralateral or no treatment control. Now, in this work, we then tested survival using doxorubicin in these liposomes and observed that we could reach 100% survival with the circle ablation plus the long circulating liposomes. And we could compare that to also in temperature sensitive liposomes, where we also reached survival of approximately 100%. Now, in our clinical trial, we now have an ongoing clinical trial in pancreatic cancer at Stanford. The goal is to use a biopsy before ablation and after ablation to be able to characterize the tissue, and then combine that with standard of care chemotherapy. In the first patient that was treated, you can observe the MRI before and also after treatment, as well as the regions of ablation shown by the ellipses here in the protocol. We're not able to yet report on the findings from this study, but we can describe the work that's motivated this study, coming from work in investigative radiology in 2014, in which 6 patients with pancreatic cancer were treated with MR-guided focused ultrasound ablation. And in that work, they observed a reduction in pain at the 6-month follow-up. They observed that the non-perfused volume was reduced and did not increase again in those patients at 6 months, but that the tumor volume that was not treated, the surrounding tumor volume, did recur or did increase. So this motivates our thoughts about how best to combine these treatments together. And in particular, we've been interested in immunotherapy since there's been a lot of progress in treating some disseminated cancers with immunotherapy, but many still don't respond, particularly solid tumors. Our goal has been to create a T-cell response through a combination of agonists and focal therapy. This is a paper by the Wary Lab that indicates that reduction in tumor burden when combined with checkpoint therapy can further improve outcome. And we see this as one of the major motivations for combining ablation with immunotherapy. Now, our work, just to give a kind of cartoon overview, the idea is to have an agonist of some kind compared with checkpoint or combined with checkpoint modulation, and to combine that with ablation. When we've done that, we've looked at the results in a couple of different ways. For example, in breast cancer, we demonstrated that there is an increase in the absolute immune score as a result of immunotherapy alone, but a further increase as a result of ablation plus immunotherapy. And similarly, this is in the distant tumors and similarly in the treated tumors. But the immune populations are very different in the treated and distant tumors. In the treated tumors, the immune response is dominated by monocytes and macrophages. And in the distant tumors, there's a greater population of B cells and CD8 T cells. We've then also used the B16 OVA model to evaluate the effect of immunotherapy on tumor-specific immune cells systemically and in the lymph nodes, in the treated lymph nodes. Here, immunotherapy was applied first, followed by ablation in this case, and one final dose of the agonist CpG at this time point. Now, the greatest proportion of tumor-specific immune cells in the lymph nodes occurred with the combination of ablation and immunotherapy in the treated tumor. This was greater than, for example, ablation and immunotherapy in the distant tumor or immunotherapy alone. We also observed, though, that immunotherapy can, with this priming protocol, can increase the number of tumor-specific immune cells, both in the spleen and blood in these studies. Now, when we combined thermal ablation with immunotherapy in breast cancer, we did see an enhanced survival. So in a syngeneic model of mammary cancer, we studied a no treatment control, a model with just ablation and a treated and distant tumor with just mechanical HIFU and a treated and distant tumor, combinations of an agonist plus a checkpoint inhibitor and thermal HIFU, similar combinations with mechanical HIFU and immunotherapy alone. And the protocol here is shown on the right, where the gray indicates, in this case, the agonist CPG, and the blue indicates the checkpoint inhibitor, and then the black indicates the ablation. Our results here look like this, where we did observe that the kind of turquoise color is the thermal HIFU plus immunotherapy, and compared with immunotherapy alone. We did observe a better response with our thermal therapy combined with immunotherapy than with our mechanical protocol combined with immunotherapy. And here, our mechanical protocol used a moderate level of pressure in insonation and not as high as achieved in histotripsy. So I know that some are seeing enhanced response with mechanical HIFU plus immunotherapy when they're using specifically very high pressures. Now, our ongoing work that is being prepared for review or under review involves single cell sequencing to identify differences in the pancreatic and breast tumor microenvironment. And what we observe between the models that we're looking at are fewer CD8 T cells and more B cells and neutrophils in the pancreatic tumor microenvironment, and that's compared to the breast microenvironment. We also see some tremendous differences in the stroma, in that in our preclinical model of breast cancer, there are a very dense tumor environment and very high tumor cell-cell junctions and tumor cell density. We think that that's responsible for the fact that we see very significant differences in the cytokines and chemokines as a result of the two treatments. So in conclusion, we find that thermal ablation likely has a place in tumor debulking, releasing antigen, and enhancing delivery. We see survival enhanced in breast and pancreatic cancer when combined with immunotherapy. And we observe that the immune and tumor cell distributions and extracellular matrix differences between tumors alter the response to HIFU. I'd like to thank the members of my laboratory who have contributed to that work, and our collaborators, including collaborators at UC Davis, Caltech, Stanford, and USC, and quite a number of members of the laboratory who contributed to this work over a period of time. I'd also like to thank you again for your attention and for the opportunity to present this talk.